information and practical guidance can make a significant difference in day-to-day care and long-term outcome. Through today's session, we aim to provide practical, real-world insight from managing fracture at home to understanding rehabilitation and mobility and to empowering patient and family through advocacy. We hope that the knowledge shared today will not only inform but will also assure and empower you in your journey. At GPED, we are committed to strengthen global collaboration and advancing equitable access to pediatric endocrine care. We believe that every child, regardless of where they live, deserves the opportunity to receive appropriate care, support, and education. Webinars like this are part of our ongoing effort to bridge gap, connect experts with communities, and amplify patient-centered care. We are also truly encouraged to see participation joining from many parts of the world. This global participation reflects a shared commitment to learning, collaboration, and improving the life of children living with osteogenesis imperfecta. We also hope that today's session foster not only learning but also connection, reminding us that no one is alone in this journey and that together we can build stronger support network for patients and families. We will also have webinar dedicated to healthcare professional on OI next week. Please register for it if you would like to learn more. We also have a webinar for World Thyroid Day coming soon too. Thank you once again for joining us and I wish you a meaningful and engaging session. And I would also like to introduce our moderator today. It is my great honor to introduce today's moderator, Dr. Somaya Aftab. Dr. Somaya Aftab is the head of Pediatric Endocrinology and Diabetes at the University of Child Health Science, the Children's Hospital Lahore. A graduate of King Edward Medical University, she completed her FCPS in Pediatric and received advanced training in Great Ormond Street Hospital. With 15 years and more of experience, she is the pioneer in pediatric diabetes and endocrine care in Pakistan, leading initiatives through such as structure type 1 diabetes training and other program in endocrine care. She has over over 40 publication and hold leadership role in global organization, including in GPED, ISPAT, SP, and also the other organization. So time is yours, Dr. Somaya.
Well, thank you so much, Agustine, for this kind introduction. So good morning, good afternoon, and good evening, everyone. So I'm really excited to be a moderator for today's session because this is one of its own kind, living with osteogenesis imperfecta, where the patients, families, and healthcare professionals will not only benefit from an engaging and informative discussion from esteemed experts, but they will also get a chance to participate by asking a lot of questions. So today we are joined by three renowned speakers who will share their experience on management of OI at home, especially the related to the fractures, and about advocacy. And at the same time, at the end of the sessions, you will have a chance to ask a lot of questions. So I'm going to start today's session by introducing my first speaker. So it is my pleasure to introduce our first speaker who will talk about fracture management of OI at home, a practical guideline for families. We are pleased to welcome Laurie Vanderbroek, who is a nurse clinician at Children's Hospital for Children, Canada, with extensive experience in pediatric care and a special focus on osteogenesis imperfecta since 2021. She is managing care for around 300 OI patients and is actively involved in OI education and international collaboration in this field. We are very happy to have you, Laurie, over here. So now it's over to you.
Thank you very much for the warm introduction. I'm very happy to be here this morning. So I will just share my screen. So I will be speaking today about fracture management at home. and how this is important for our OI population. So in the first photo here, it's myself, my nurse practitioner, Nadia Narducci, our orthopedic surgeon, Dr. Hamdi, who has trained under Dr. Fassi. I'm sure a lot of you know Dr. Fassi, who created the Fassi Duval routing that we use in our OI population, and as well as Afia, one of our OI patients. And this is a photo of the Shriners Hospital. This is in Montreal, Canada. We have the old Shriners and now the new Shriners. So who are we at the Shriners? We're actually a very large team that takes care of our OI population. We have, as I mentioned, Dr. Hamdi, our orthopedic surgeon. We have Dr. Frank Rauch. We also not pictured are Dr. Sprocki and Mary-Eve Robinson. Dr. Robinson will be presenting next week. We have our physiotherapy, Corinne, who will be speaking next. And then as well as an occupational therapist, a nurse practitioner, a research team, a genetics counselor, and a social worker. So what do we do when a fracture occurs? The most important thing to remember is to try to stay calm as parents and caregivers. This will greatly impact the success of your child. We only make necessary movements and we try to be as gentle as possible. If your child was to fall, we try to leave them in the position where we found them. So if they fall on the floor, it's better to actually get down on the floor with them and comfort them there before moving them quickly to a different position. And then we want to assess and immobilize that limb. So why is it so important to be calm? Well, there's this vicious circle of pain. So the more calm the caregiver is, the more calm the child will be. And you'll see that circle here of pain. The more pain they're having, they have stress. It can lead to muscle contractions and limb movements, which creates more pain. How do we know if a fracture occurs? Sometimes this is easier in the older, maybe teenage or adult population, but can be more difficult in younger children. But you may hear a fracture, you might feel the fracture. The pain might be localized just at that one site. The injured limb may have a different shape to it. You might see a deformity. The child may cry, or there might be an absence of movement in the affected limb. So this is often the case in our very young babies or children. They might have fractured, and then suddenly a child that might have been crawling normally stops crawling or stops using one arm. And if you touch it, then they start crying. So then you can suspect maybe perhaps they have fractured on that side. So why do we need good immobilization? We need something that is light, something that's comfortable and provides good support. We always need to be prepared when a fracture occurs. This is very important. At the Shriners Hospital for Children in Montreal, we had the pleasure of having one of our patients who's pictured there, the young gentleman, Carter Brown. He introduced what's called our fracture kit. And it's a kit that we give to all our patients with supplies in it. So there's a list of supplies shown on this screen, and it's different medical equipment, different bandages and wraps that we can give to our patients with explanation of how these can be used to immobilize a fracture at home. So we're lucky enough to be able to provide this service to our patients, but not everybody is a patient at the Shriners, and we recognize that this other child picture, she's from Mexico, and she actually made a kit herself. Some patients call it their break bag, so they can be ready if a break occurs. So they have different material in it. She also has Tylenol or acetaminophen for pain relief. So they carry this little bag with them wherever they go so that they're ready when things happen. So principles of immobilization. We always want to immobilize the articulation above and below the fracture site. So for example, if your forearm was to fracture, you would immobilize the wrist and the elbow as well. Often back slabs or half casts or splints are used instead of full cast. These are lighter and it will decrease the risk of a fracture at the end of a heavy cast. A Jones dressing is a very good option when supplies are limited. This dressing is highly padded and bulky, and it can stabilize the limb and also helps reduce swelling. And so that's just the basic concept of wrapping and wrapping and wrapping around the affected limb multiple times. So even if you don't have necessarily medical supplies at home, the same concept could be used, for an example, with a scarf cut in strips, and you just keep wrapping that immobilized limb so that it's well protected and the child is able to move a little bit less. So why is this important? So correct immobilization is critical in promoting proper fracture healing, relieving pain, but also allowing a little bit of freedom of movement in the healing process. A heavy cast could have what's called the leverage effect, and this is when a cast is too heavy and finishes before the end of the bone. So for example, my arm, if a cast was to finish here in an OI population, well, the rest of their bone is not protected. And if that cast is too heavy, you actually risk fracturing at the end of where that cast is. So that's why we need something that covers an entire limb. And the type of treatment will always depend on what bone is affected and the type of injury. How long do we need to immobilize for? The duration will always depend on the affected bone and other factors such as the OI type, the age of the child, the location of the fracture, and the type of the fracture. So following our general guidelines, nothing is concrete, especially in OI patients. The standard for care at the Shriners for long bones, for example, the femur or the tibia, we would say generally 6 weeks, the limb should be immobilized, 4 to 8, but 6 weeks is about standard. For upper extremities, also 4 weeks is closer to the average. We say don't immobilize the elbow for more than 4 weeks because we don't want to have risk of contractures in that elbow. For the upper arm, the humerus, a sling can be worn for about 4 weeks, and you'll see a picture of that in a minute. A collarbone, we don't necessarily always treat a collarbone. However, a sling can be worn for comfort, often only for about 2 weeks, and then the patient can gradually increase their range of motion as tolerated. Fingers and toes, these can be buddy taped for about 2 weeks. I will get to a picture of that. Vertebral compression fractures, so any fractures of the spine, of the back. These are more difficult to treat. Often a brace is given for the first few weeks just to provide some pain relief and comfort for the patient. If you don't have access to a brace, if you're able to have maybe again a big scarf that can just be worn around tightly with some padding just to provide that extra comfort. But a full recovery of vertebral compression fractures really depends on bisphosphonate treatment in our OI population. For foot fractures, generally it's about 4 weeks that the patient should be non-weight bearing, and hands can be 2 to 4 weeks, so it should be splinted until the pain improves, and then it's always a gradual return to mobility. When is an X-ray required? So our patients in Canada, we're lucky enough that they're able to have access to X-rays. So patients will often splint at home first and then go to the hospital for X-rays. That might not be the case for everybody, which we understand. But we would suggest an X-ray is important if it's a long bone fracture, especially any bone that's visibly displaced. For sure, any open fractures, it's a medical emergency, and there would be a higher chance of those requiring surgery. If pain does not improve after splinting after a few weeks, then you could get an X-ray to make sure there's no bigger issue. And due to the nature of OI population, we know that their bones don't always heal the same way as normal bones would. So here's a picture of buddy taping. So the same concept can be used for fingers and toes. What that is if you have a break in one of your fingers, you tape it together beside the finger that's the closest in size, and you put a little padding between the two just so you don't have any pressure sore that would develop. An emergency room visit, when is it warranted? Again, it depends on your access to emergency rooms and medical care. But one thing that's important, if you do go to the emergency room, make sure the medical team knows that you have OI. Not everybody knows what OI stands for, or even osteogenesis imperfecta. You might have to use words like brittle bones or fragile bones. We're always surprised when our patients go to a different emergency room and they don't even tell the medical team that they have OI. So make sure the people that are handling you, the nurses and doctors, x-ray techs, know that you do have fragile bones. If you do need a cast, we often advise using a heavy cast. Again, if a lighter cast or a back slab can be used, that's always recommended because they're lighter. If surgery is required, if your doctor does not know OI and has never done these surgeries before, we have Dr. Hamdi, Dr. Bernstein, Dr. Janelle. We have a wide range of our orthopedic doctors at the Shriners who are always more than happy to help answer questions about surgical options. The following slides are just ideas of when you have a fracture, how much of that bone has to be splinted or cast. So it always looks bigger than the fracture is. And again, this is just to make sure the bones beside are also protected. So a foot fracture, usually we would immobilize up until below the knee. For a tibia fracture, that goes almost until the top of the femur. If it's a femur fracture, and it depends on the age of the child, but they could end up in a very long leg cast or even a spica cast, which would go above the waist. A hand fracture, these could go up to the elbow. Forearm fracture up past the humerus. For a humerus fracture, these obviously we can't put casting on, so the correct positioning is making sure that the arm is close to the body and that arm is aligned with your side and kept in a nice tight well position. When we're using any elastic bandage, we want to make sure that we're wrapping it towards the heart, and that just helps for your circulation. These are just examples of how an arm and a shoulder immobilizer could be useful. And this is a Vietnam sling type, and you can see that it's kind of a do-it-yourself type. And we always say be creative at home. Not everybody will have access to these wonderful fracture kits that our patients do, but that doesn't mean you can't do anything. There's lots of things at home that you can use that will make a very good splint, okay? A scarf is a great option. You can see the triangular bandage there that you can use as a sling for either the upper arm, humerus, or collarbone. In one of the pictures, we see people have actually used pieces of wood on a tree. That might be great for short term. Obviously, you have to be careful not to risk hurting your skin. But slabs of wood, pieces of cardboard that can be cut in strips to immobilize that limb and then well wrapped to secure it in place. If you have any old casts or splints that are still functional, even if they're a little bit dirty, as long as they're still working and provide that good immobilization, that's really the goal. Homemade splints for lower extremity fractures. So in this picture, you see an old back slab was used, and then there was Velcro straps that are used on one side to immobilize the fracture. In the very small babies population for the humerus, we actually used a cohesive bandage, and it goes around the entire body, and that keeps that limb tight to the body. You may not have access to this material, but this is a soft spica splint, and it just gives you an idea of what is possible if you don't have access to all the type of fiberglass cast. So once it's well wrapped, then it's wrapped with the ACE bandage, and that really goal here is to keep that position of the femur nice and straight and in line, and it goes up around his waist and then is protected with some waterproof tape. Neurovascular sign. So this is very important both after a fracture occurs and once a casting or a splint is put on. And what that is to check your circulation. For example, if it's an upper arm, you're looking at the fingers, and if it's a lower extremities, you're looking at the toes. And so circulation, are your nail beds nice and pink? Is the color returning? You don't want them to be blue. The temperature, we want to make sure they're warm, they're not hot or too cold. Mobility, I'll show you in the next slide, as well as sensitivity. Swelling, you're going to compare the two sides. You want to make sure there's not too much swelling. Pain, again, very important. So for sensation, you can ask your child once the splint is on, are you able to feel the tips of your fingers? Can you feel the space between your thumb and index finger? For mobility, are they able to open all their fingers? Can they open their thumb? So basically, can they give a thumbs up, an okay, and touch their pinky and thumb together? For the foot, you ask them, can they feel the top of their toes? Can they feel the sole of their feet? Can they bring their toes to their nose and back to the ground? So to conclude this part, if access to medical care is difficult, it's really important that you're comfortable to splint at home. If supplies are limited, you have to be creative and use what you have at home. We say it's always better to immobilize than not, especially if you're not sure if there's a fracture. Even patients here that have had x-rays done, they may not know, or it's not seen on x-ray that it's a clear fracture, but the advice we give is it's better to immobilize anyways, because often that's the best case for pain control. So even if they end up immobilizing a certain area just for a couple days, and if the pain disappears, then we can tell them they can take their splint off. If the pain's still there, they can continue to immobilize for a few weeks. And the most important reasons to splint a suspected fracture: immediate pain control. It's going to promote bone healing, and then it's going to decrease the risk of deplacing that bone further. Even our patients here that have access to emergency rooms, sometimes they're driving 30, 40 minutes to get there on our bumpy roads, and then they're waiting up to 12 hours in an emergency room. So that's a long time for this bone to be broken without any kind of support. So really keep that in mind, that the most important thing is just to have it protected even while you're waiting for medical care, if that's an option. And last, I just want to talk about the referral pathway to be a patient at the Shriners. We're lucky enough that we have an expert panel and team working with OI. The Shriners has been around now for 100 years, with OI always being the center of our care. And we see patients from all over the world. So how do we have these patients? They have to fit within a criteria. So they must be within 18 years of age or younger, within a scope of our care. So it's not just OI that we see, it's all types of bone conditions. In order to do that, they have to apply online at the Shriners website, and every patient goes through the same process. They apply online, and then it's triaged by our global health headquarters. So me personally, I have nothing to do with the selection process. I often get emails asking to be a patient, and I can't, it's not up to me. Everything really has to go through the bigger headquarters. They go through a screening process of helping get your medical file and reviewing it. From there, once they ensure everything is okay, they'll make sure that every patient coming has a sponsor. So that's usually a family or a connection, somebody maybe that's from Africa, for example. If you're coming from Africa, if it's an African family that lives in Canada and they find that connection, that person can act as their sponsor. So helping them, take them to appointments. Sometimes they actually stay with them or provide financial support. Again, with the headquarters, they make sure that there's enough financial availability to these families. The families must be able to cover their flight to Montreal. And then once they're there, all their medical care is provided for. And so once the finances are aligned, then they receive a letter to help get their visa, and then the patient must have a valid visa to come. And then these patients can end up staying just for 2 or 3 days for an assessment, or some of them stay up to 6 months while they have multiple surgeries done. So it's kind of a long process, but our patients, once they do get to the Shriners, are very grateful for that. And there's other Shriners, not just in Canada, but also in the States and Mexico as well. So these patients that apply are triaged to all the different hospitals. There's some references for your viewing. So these are different videos that the Shriners puts out on how to immobilize. It's the material that's used in our fracture kits that I spoke about, as well as different other videos on different bone conditions for the Shriners. And then the last one there is the Shriners Children's website where you can go to apply to become a patient. And so that's it for now. Thank you very much for listening to my talk, and I will pass the floor back over to Dr. Soyamaya.
Yeah. Well, thank you so much, Lori, for such a informative and honestly very practical presentation. And I'm pretty sure that it will be very beneficial for all the families and even the healthcare professional who has joined this webinar. So we are moving towards our next speaker, and our next speaker will talk about post-fracture rehabilitation, motility, and maintaining function in OI. We are really pleased to welcome Corinne Marsai, who is a physiotherapist at Shriners Hospital for Children, Canada, with over 20 years of experience working primarily with children with OI and their families. She is very well known for her holistic approach with a strong focus on active living, adapted sports, and school inclusion. She has extensive clinical and international teaching experience and has contributed to research and education in OI worldwide. Thank you so much, Corinne, for being a part of this webinar. Over to you.
Good morning, everyone. I will start by sharing my screen. Share. Can you see it?
Yeah, we can see your slide.
Wonderful. Okay, so good morning, everyone. I'm Corinne. I'm a physiotherapist. I also work at the Shriners Hospital in Montreal, and OI is one of our specialty. So even if OI is a very rare condition, like Laurie said, we see lots of children with that condition coming from all around the world. So over the years, I had the chance to meet with hundreds and hundreds of children with OI and their families. And I feel very thankful for that, because working with children with OI, it's not something that you...
is being recorded.
Working with children with OI, it's not something that you learn at school. Sorry, there's some echo. Okay. Working with children with OI, it's not something that you learn at school, at university. You learn by meeting children and meeting families. So everything that I know, actually, I've learned from you, and I'm very thankful for that. And I will try my best today to share what is it that I've learned from you over the years. The plan of the presentation, first of all, we're going to talk about rehabilitation after a fracture and going back to an active lifestyle. We're going to talk a little bit about sports and OI and fracture prevention. And I'm going to ask you to keep your questions after the third presentation. These are some general principles for rehabilitation after a fracture. I'm going to just read them out loud, and then we're going to look at them one by one more in detail. So you want the child to restart moving as soon as possible once the fracture is healed. You want to consider all the aspects of rehab. You want to progress gradually, and also you want to consider the emotional state of the child. Why is it that we want the children to restart moving as soon as possible once the fracture is healed? Is because we want them to have strong bones. There's a correlation between bone strength and muscle strength. The stronger the muscles are, the stronger the bones will be. When muscles are contracting, they're pulling on the bones, and the bones, they will react by getting stronger. So unfortunately, every time a limb is immobilized, the muscles are going to get weaker, but also the bones are going to get weaker. So there's that period of immobilization that is absolutely necessary when there's a fracture. But once the fracture is healed, then you want the child to restart moving, just to prevent some more weakness of the bones. Also, one thing that is good to encourage is good to encourage the children to move the arms and the legs that are not immobilized, just so they maintain their muscle strength and bone strength as much as possible. So you see that little girl with moderate OI who has a tibia fracture. It's good that she moves her arms. It's good that she moves her right leg gently. She can even be encouraged to scoot around on her bum in her house, just to prevent as much as possible that decrease in bone strength, that decrease in bone mineral density. This is probably the slide that I've shown the most over the years when presenting to families and professionals. It's the importance of being active when you have OI. So we want to encourage the children to be as active as possible in a safe way, to have stronger muscles and also stronger bones. And very likely, if the children they have stronger bones, they're going to have less fractures. And if they have less fractures, they're going to be less immobilized. And if they're less immobilized, then they can remain active. So this is really what we want to encourage right from the beginning. Okay, number 2, consider all aspects of rehab. So we have that little girl with moderate OI who had a tibia fracture. Like Laurie mentioned, when there's a fracture, you want to immobilize the joint below and the joint above. So you can see that she's in a cast up to the top of her femur. Once the cast is going to be removed, what is that she's going to have to work on? She's going to have to regain joint mobility and muscle flexibility. She's going to have to regain some muscle strain, but also cardiovascular fitness. Joint mobility and flexibility. How is it that we do that? First of all, you want to encourage a child to move on their own as much as possible, so they feel in control. Also, let's provide some exercise for the muscles. But then if you want to help the child to gain a little bit more flexibility, you want to do it very slowly. And also you want to maximize the contact area where you put your hands. So you see on the picture, I do a stretch of the hip. My hand is wide open. It's on the whole femur. I'm pushing gently. That's a lot safer than pushing just on the knee, for example. That would provide a lot of stress on the femur. So regaining joint mobility and flexibility. Also, very, very important, strengthening. After a period of immobilization, muscles are going to be weaker. So the child can start just by contracting the muscles without even moving. Just, we call it like static contraction. So just contraction. Once this is possible, step number 2 is to encourage the child to move without the resistance of the gravity. So I'm giving the example of the muscles on the side of the hip. So this is picture number 1. We're working the hip abductors muscles. So you see, we encourage a child just to open the leg to the side and then come back and do repetitions like that. So we're working without the effect of the gravity for the muscles on the side of the hip. Once this is easy, then we want to work against gravity. So the same, so the idea, we would have the child lay on their side and lift up the leg against the effect of the gravity. So that's a little bit harder. And once this gets easy, then we want to add some resistance. So resistance can be added in different ways, adding a little weight, for example. Sometimes I give the families the example, just take a little bit of bag of rice and tie it around the leg of the child, or just having like a shoe or boot on the foot provides a little weight and provides some resistance. So that's all different ways to increase the resistance. If the fracture occurred in the arms, a good way to do strengthening is to have the child play with some little toys or little object and lift them up. And if the child or the teenager wants to do some more formal strengthening, I often give the idea of taking some water bottles and just putting a little bit of water in it and do some repetitions, bending the elbow, lifting up the arms to the sides. And as the child or the teenager is getting stronger, then you want to add more and more water in the bottle, so it gets harder and harder. A little bit of a magic number is number 10. If a child can do 10 repetitions of an exercise, probably he's ready to progress to the next step. So when we prescribe exercises, we often prescribe 2 or 3 sets of 10 repetitions. And then the child should be a little bit tired after doing his exercise program. If the fracture occurred in the lower extremities, we want to think about restarting to stand. Very likely the child will need some support of their arms to restart standing and walking. So that can be done using a walker if it's accessible for you. That can be done holding on to furniture, so holding on to a table, holding on to a chair, for example. Also holding on to the back of a wheelchair to stand and restart taking some steps work really well. as long as there's someone sitting in the wheelchair or there's something heavy in the wheelchair to make sure it doesn't tilt. So that's some ideas. Also, you have access to a pool. The buoyancy of the water helps to support the body weight to restart standing and walking. So that's just some ideas if accessible for you. Using body weight is a good way to do some strengthening exercises. I really like the exercise that is just sit to stand. So having your child sitting on a little chair or a bench and standing up and going back to sitting and standing up and sitting and doing repetitions like that with or without the support of their arms, depending on their strength and balance. That works pretty much all the muscles in the legs. Doing some step-ups is a good way to strengthen the legs. Wall squats, so having your child lean against a wall and just going up and down, bending the knees, that works especially the quad muscles in the thighs. Doing some squats. And if we think about the arms, doing some push-up on the knees, like you can see the picture on the top right corner. So we talked about range of motion, strengthening, and I want to say a little word on hyperlaxity. It's not completely related to the topic of the presentation today, but I think it's important to mention it. We always think OI, it's a bone condition, and it's mostly a bone condition, but it affects also some other structures in the body, including the ligaments. So often people with OI, well, they have weaker bones, but they also have weaker ligaments. This is what we call hyperlaxity, and that can cause some different deformities in the feet, in the knees, in the arms, in the spine. And one solution to hyperlaxity is to have the muscles around the joint as strong as possible. So if the muscles around the joints that are hyperlax are as strong as possible, they're going to be more stable, and very likely the children are going to have less pain. So that's another reason to do some strengthening exercises in the arms and the legs, but also around the spine, working the abdominals. The spine, it's many little bones, one on top of each other with some little ligaments in between them. So we want a strong core as well. Cardiovascular fitness, if the child didn't move for a little while, didn't exercise for a while because of fracture of an immobilization, very likely also their heart and lungs will not be as strong. So you want to start gradually, slowly, with maybe shorter duration of physical activity and exercise, but more frequently throughout the day. It's better than to try to do a lot at once, and then the body is not ready for that. Emotional state, having a fracture, it's a trauma. So children can be really scared or restart to move after a fracture. It have been shown in research that fear can be a significant barrier to restart moving. So you want to go slowly. You want to have good communication to the child, listen to the child. They really know their body best. When I work with children with OI, I always make sure to ask them, are you comfortable doing that? If I'm asking you to do anything and you're not comfortable, please, you let me know. And we work together. So we're working with physical health of children, but also mental health. Underline successes and congratulate all efforts, encourage them to keep going. It's good for self-esteem as well. And things that you can do for children to be as comfortable to restart moving as possible is to encourage them to move on their own, so they feel in control. But if you have to move them, the same principle then when you do some stretching exercises, really open your hands, have some really large contact area so they feel supported. Also, if you have access to water, the pool, bath, moving in the water really helps. And I want to say a word on support from caregivers. So we're the one taking care of those children. So if we're calm when we take care of them, very likely they're going to be calmer. Children, they're little sponges, so they feel everything that we feel. So fear and anxiety in caregivers can translate into fear and anxiety of children. So this is something to keep in mind. If it is really difficult for you to encourage your child to move, maybe you can speak with people around you, or maybe other parents of children with OI. I know also that there is some support groups on Facebook, for example, for parents of children with OI. So I think that can be a good idea to exchange with some other parents, exchange experiences. just to work on your own emotional state. Now, going back to an active lifestyle, you really want your children to be as active as possible and really throughout the day. So if your child is not able to walk, maybe they can scoot at home or crawl at home instead of being carried or instead of using like the wheelchair all the time. That's a way to exercise. If your child is able to walk, then encourage them to walk in the community, walk to go to school, walk to visit some friends, maybe just walk to go see the neighbor. Dance. Everybody loves to dance. Well, almost everybody loves to dance. So just like dancing to the music, that can be done standing up, sitting down, sitting in a wheelchair, even like lying down. That's a way to be active physically. Playing outside. And I've put the example, rake the leaves. I'm from Canada, so every year, like around September, October, we have to rake the leaves to get ready for winter. And this is something that families they do together with the kids. So even if you have a child with OI, the child would be encouraged to come outside and participate to that family activity. It can be done standing up, even like sitting on the grass or crawling on the grass. So this is just an example that activities can look different depending where you're from. So I really encourage you to have your children included in your family activities, have them participate as long as it's safe for them. You really, really want to aim for a minimum of an hour of physical activity per day. And that brings me to talk about the last point, reduce screen time. Screen time, it's really a major issue in North America. It had been shown that there's a lot of damage on mental health and physical health of the population because of excessive screen time. So this is something to keep in mind for everybody, especially for children. Okay, less screen time and more physical activity time. Another way to be active is to participate in sports. I agree that children with OI, they cannot participate in all kind of sports, but there are some sports that are considered safe for people with OI. So these are just some examples. Swimming, biking, tricycle, pedal exerciser, like you can see on the picture, that can be used with the arms to exercise the arms or the legs. Archery, dance, as I mentioned before, yoga, juggling, brisk walking, hiking, climbing stairs, pushing a wheelchair, sports in a wheelchair if it's accessible in your community, and any other idea you might have. It's really the contact sports that we don't encourage. Gym class. Participation in gym class is strongly encouraged if it's possible. Of course, parents should inform the school of the condition of their child, and we encourage participation in non-contact sports. If the child cannot participate in a sport or an activity, we suggest maybe that they do something else. One thing that is good to do is to teach the child to advocate for themselves. So having the child being able to explain their condition, what is it that they're able to do, what are their strengths, but also explain their limits and that they have fragile bones and there are certain things that are not safe for them. The child should be allowed to rest if they're tired or if they're having pain. And I wanted to mention also that sometimes just doing the ref or counting the points in gym class can be a way to participate. So it's good to be included in the group. It's good for self-esteem, and yeah, it's a way to participate as well. So there's health benefits. So many health benefits to do physical activity. We know about that, but I think it's always a good reminder. So it's a good way. It's a good way to meet people, to make some friends. It improves fitness, it improves concentration, and it helps performing at school. It's good for the heart, it's good for the bones, it's good for the muscles. And I underline bones just because we're talking about a bone condition. Healthy growth and development, improved self-esteem, better posture, and I'm correcting my posture as I say that, better balance, and lower stress, and it helps also with better mental health. So we talked about recovering from a fracture, but we want fractures to happen as little as possible. Unfortunately, the risk of fracture is never going to be zero when you have OI, but there's ways that we can decrease that risk of fracture. So we've developed some little guidelines that at Shriners, and we called it the ABCs of fracture prevention. So I'm going to go through those 3 slides. So the first one, A, avoid rushing. So plan ahead, take your time, avoid twisting motions, because it's really the movement that is the most stressful for the bones, that twisting movement. For example, a few months ago, Laurie, you're going to remember that, we had a teenager boy with OI who came to our clinic, and he had a humerus fracture from doing a high five to his friend. So he had the fracture here because of the twisting, and the forearm was fine because the forearm moved in just one plane of movement. So really avoid those twisting movements of the bones when possible. B, be aware of stairs, uneven surfaces, indoors and outdoors. Be aware of sudden movements of animals and young children. They can be really unpredictable. Be careful in crowds. Be aware in bathroom. Water on the floor can be very slippery. Be aware of your spine. It is fragile too. So be careful with too much jumping or jumping from heights, or for example, sitting in the rear of a bus when the road is really bumpy is really stressful for the bones of the spine. It's better to sit in the front of the bus. For example, think about your posture, sit straight and buckle up. If your child is using a wheelchair, make sure that they buckle up. And if there's no seatbelt on their wheelchair, then maybe you can create one yourselves. Like, for example, using a scarf or just using like a regular belt to make sure that there's no incident falling off the wheelchair. C, choose to wear well-fitting shoes. Choose an active lifestyle for strong bones, as we've been talking about, and choose recreation activities wisely. Swimming is safer than soccer, for example. I have 2 take-home messages, okay, just because I couldn't choose. The first one, it's a slide that I've shown before. So really the importance of being active as much as possible in a safe way to have stronger muscles and stronger bones, and then hopefully less fractures. And if there's less fractures, there's going to be less immobilization. And if there's less immobilization, then the children can remain active. So this is really, really what we're looking for and working towards.
Yeah.
And my second take-home message, I spoke about that teenager boy who had the arm fracture from doing the high five. And a few times I heard his mom saying that. It's not the number of times you fracture that counts. It's the number of times you get back up. So unfortunately, fractures will occur, but they're going to heal. So hopefully we can teach the children to be as resilient as possible and have a very happy life despite their conditions. So I think we're going to keep questions for the
this will be at the end of the session. Thank you so much, Karini, for such a wonderful presentation. And honestly, your presentation breaks a lot of myths about mobility and OI. So we are moving towards our last speaker, and Dr. Specky is an anesthesiologist and a pain specialist from Kenya, and she's a co-founder of a social enterprise focused on improving our orthopedic care. She's an experienced clinician and a strong advocate for patients with complex bone disease, including Osteogenesis imperfecta. And I'm very glad to invite her to talk about one of the most important aspects of Osteogenesis imperfecta, that is advocacy. Thank you, Specky, for joining us. And now it's over to you.
So good evening, good morning, and good afternoon. So my name is Specio Sanguku. Everyone calls me Specky, and my journey in osteogenesis imperfecta started as a person who's been giving anesthesia. So I started working in a hospital where we were doing many children who had osteogenesis imperfecta, and that's where my journey began. So I work in a clinic in Kenya, in a rural town called Machakos. And so this picture here, the slide here is of some of our patients. The lady in blue is the mother of this boy. She's called Mama Maxwell, and she's one of our great patient advocates. And I just want to share some of the stories, and hopefully will help us to see how we can be able to advocate for more for care. So this is a time when they came for administration of zoledronic acid that were given in the clinic. And so we are going to talk about what a patient advocate is. We'll talk about why it is important to be one. What are some of the challenges that patients with OI face? And what are some of the ways that we can be able to solve some of those problems as patient advocates? And so what the picture on the left is a stool that really helps us to think about, whenever we're thinking about osteogenesis imperfecta, we try to think of how to manage these three things. So we have this three-legged stool, and it is supported by prevention of the fractures, corrective surgery with telescopic nails, and then finally rehabilitation. And so when you think about those three things, when you're thinking about the OI patient, think of them in all these ways and seeing how we can be able to make their lives better. And so what is patient advocacy? Basically, it means the act of representing and pleading on behalf of a patient. And this is a patient who is vulnerable, and this is to ensure that their rights are upheld and to improve access to quality treatment and care. And through this, you'll be able to influence healthcare policy, decision-making, and raise awareness about these issues. So basically, it's just fighting for the rights of these patients and ensuring that they get good care. And so why should you be one? Basically, it's just to help improve the quality of life for an OI patient. The OIFE, which is the Federation of the European Federation of Osteogenesis Imperfecta, say that an OI patient advocate has two main roles. One of them is to improve the quality of life of the patient with OI, and through that they change the quality of care that the patient is receiving, and they raise awareness. And ultimately, because of participating in research and better treatment options, then hopefully one day we might have better treatment, and who knows, one day a cure. And so when improving the quality of life, you're trying to look at all these aspects of our patients' life, the health, the environment, their belonging, their work, the emotional well-being, and their social relationships. And so there's this interesting study that was published, and Marie Robinson, who is also one of our members here, was part of this team that wrote this article about facilitators and barriers to care for patients who are living with osteogenesis imperfecta. And through that, they were able to look at what are some of these barriers and things that improve their care. And specifically for barriers, there were 8 of them, but I just mainly focused on 6 of them. And some of them are like insurance. So insurance status. If a patient does not have insurance, like in our setup here, if your insurance limit has very low limits, or your social health insurance, you've maxed it. As in our situation, you're only allowed to have at least 2 major surgeries in a year. And with a child who has osteogenesis imperfecta, they could fracture more than 1 bone. And so having 5 fractures a year, it means several of them will not be covered. And so that is a barrier to care. And then different places have challenges in genetic testing and bone density scans. These are not routinely available in many developed places like in our place here. And so that is an issue. Then affordability of drugs like the zoledronic acid can be a challenge to patients. Then location. People have to travel quite a long distance. Like in Kenya here, we, apart from some private facilities, we are kind of like slightly in the center, just almost slightly center of Kenya. But you have patients coming from all over the country coming to receive the zoledronic acid in our facility. And so the distance is a big barrier for them. And so healthcare is more accessible in urban areas than in rural areas, and especially in our area, where we have the majority of patients who have osteogenesis imperfecta. Then challenges with pain management. These are people who are constantly fracturing, and when they go to facilities, the health workers are biased about the pain, and so they do not understand that you're in pain even though you have microfractures and you're constantly living in pain. And so also because of these biases, patients fear to speak up, and that can be a big barrier to getting treatment. And so encouraging the patients to actually talk about what you have and explaining. Then stigma, which I'll talk a bit about later, lack of resources, challenges with biphosphonate access in many countries. Some of the countries, I remember chatting with a colleague who was telling me that they had run out of zoledronic acid in their country, in one of the countries in Africa, and she was asking, can you loan me some? And so I'm like, okay, send me your address. We just packed it and sent it to her so that some of our children do not miss a dose. And then lack of challenges with surgical access. We are slowly moving on to having more of telescopic nails. We've been mainly using the rush rods, and so that means after 2 years you have to change this, and that becomes quite costly to patients. And then lack of multidisciplinary care. So not all of our facilities are like Shriners where you can get everything, surgery, the medications, physio, and mental health in one place. So you find these patients are coming to us for medication, they're going to another place for surgery, or even they have surgery here and other issues. So that becomes a challenge. And so if we can be able to get more things under one roof, that will really, really help the patients. But we are growing and getting better with time. So stigma is another barrier. So many of the families, especially in our situation, congenital issues are really a big issue. And so families have a lot of strife because of osteogenesis imperfecta. So you'll find a mother is left by her husband and her family because we do not have OI in our family. Why is it that now you've gotten this? If this has come from your family. And so explaining that this is not anything that the mother did wrong, it's not from that there's something wrong in my side that happened, those help to reduce the stigma. Then societies, many of the children are kept hidden who have these fractures. Some of them have never been to school, they've never been out. And some of them are actually abandoned by their parents or even by their relatives. And so that becomes a very, very big barrier. But so if you are able to manage them, then at least some of these issues become less. And then schooling, some of them, when they go to school, because of the fear of fractures, they're told, do not go for parade, do not go for games, don't even go to the toilet. There's a child who told me last year that when they need to go to the toilet, they have to call the mom who is 1 kilometer away to come and carry the child and take them to the toilet. And so this really interferes with the child's socialization. And that was an issue. But then there are things that have actually been shown to help. Telemedicine has helped to, especially for consultation. Some parents just call you and tell you I'm fractured, what do I do? Showing compassion and empathy, that is the biggest thing that as health workers, when we do, it really helps. Patients with OI people with OI don't want pity, they just want to be normal like everyone else. And then just being open to listening to the patients really, really helps. And so it's important as a parent or a patient with OI to talk about your care, because the health workers are open to listen, especially when this is about a condition that people are not aware about. You might actually have more information than anyone else. The other day, a child told me that I don't shake hands, I just wave, I don't high five, I don't give a thumbs up, I don't fist bumps, I just wave. And so when you listen to them, you actually learn a lot of things. And so please do not fear to speak up about what works for you. There's some children who tell me that you're struggling to find a line, there's usually a line over here. This one has not been touched. So speak up and tell them about your things. Talk to the people who are willing to listen, and they'll be able to help you. Look for trusted online health education. There's a lot of myths out there which do not help in our management. And so if you're able to access trusted health education, you're able to know what is best for helping yourself and also helping your loved one, and then also improve your quality of life. Then access to scientific literature. So as you listen, read and research, there are free articles online that can actually tell you what works. And as you share this with your health workers, they will be able to listen. So what should you do as a healthcare advocate? There's just 3 things. If you forget anything, just remember 3 things. Learn about OI. You overlearn it. Link up with people who are in a community and learn from other people, and then take action as a leader. Learn, link, and lead. And so some of the things that can actually help is being part of a peer support community. So for us, we have found that there are all these groups like Facebook groups, trusts, foundations that people can come up together. But we found that having just something as simple as a WhatsApp group has been a source of big encouragement to our patients. And these are some of the patients who are coming together at the same time to receive the zoledronic acid. And as they're talking, they're encouraging each other. Through the WhatsApp group, you're able to mentor and monitor newly diagnosed patients, and people can be able to share their real life experiences, and that really has great impact.
This is the time when we were given permethrin before we moved on to zoledronic acid, and we'd admit them in the hospital for 3 days. And this is our patient with oldest patient with OI, and he was just encouraging them and sharing with them his life experiences. This young man now is 20 years old. He's almost finishing high school. This one has finished high school. The rest are in primary school. And so as they're talking and interacting together, they're able to encourage each other. Then every child deserves to go to school, but also school has its own challenges sometimes. Sometimes the distance to school can be a prohibiting factor. So sometimes you find parents want to move closer to the school. In our situation here, sometimes it makes sense for the child to attend a boarding school for the children with physical disabilities. And we have one which is just close to our clinic. And that has really helped, especially with some of these barriers, because if they're told to get into a motorcycle and there's a bad road, there's bad weather, that's a risk of a fracture. Some schools have a very bad terrain, the children cannot be able to cope. And so moving to a school that is safer is actually helpful. And then a lot of misconceptions. Some of the children are not able to cope well in other schools because they're not allowed to go for sports. And yet we've just heard that exercise is quite helpful. And so start, even with schooling, find a school and talk to the teachers, explain to them what are the issues, look at what are the issues in the school and try to see what you can do. Even if your child delays in their milestones, don't worry about it. The goal is to finish school. There's no harm in finishing high school in your 20s because you've had multiple fractures. Look at the challenges in the school and try to see what works. For example, like this boy he fractured and he said that he doesn't want to miss school because he loves his friends there. And so he had a spiker. So he had a conversation with the school and the school allowed him to go to boarding school with a spiker. And so schools, depending on how you interact with them, they can be able to accommodate the child. And this is just a slide just to show you that it is possible to go to school. These are children from that school of the physically disabled who are in primary school. One of them actually scored highly and went to a national school, which is a very difficult to get into. And then this other young man is now in university and he's been able to overcome some of those challenges. And so exercise, we've talked a lot about exercise. I'll not dwell much on it, but it is possible for children to actually have, who have OI, to have exercise. And the more exercise you have, which is safer for the child, you actually improve your muscle mass and that reduces your risk of fractures. And it has a lot of improvement in outcomes. And this young man here is called Aslam. He said that last year that he wants to walk, and he had never walked before, and he's around almost 14 years old, and he wanted to start walking. But in his school, he started doing some small exercises like walking, and even at home trying to walk supported with something, with a stool, and then slowly he got involved in swimming, wheelchair basketball, and other things, and physiotherapy. And he was able to start walking. And this is a video that was just taken a few weeks ago, where the parents sent to us that he is able to start walking. So career and work, you are able, even if you have osteogenesis imperfecta, you can actually have a productive life. This lady here, she's now close to 40 years old, and she works as a very senior role in the government. And she said that one of the things that she said, that her mother is her biggest fan, her biggest caregiver. And because of her mother, she's been able to work and do a lot of things. And she has been decorated. She went through paramilitary training, which is even hard for normal able-bodied people like us. And yet she's a young lady who was born with a fracture, but has been able to go up and even have a wonderful career. And she says that we should keep striving whatever opportunity that comes up. When people are asking her about her journey and they're shocked about her skills, especially when they walk into a government to get a national ID, and they're shocked by seeing her. She's able to explain explain and work well with them. And she says that to the amazed, the people who are shocked by her, she's never distracted by the people who are amazed by her, because she always thinks that whatever opportunities she has, that she can be able to do so. Yeah. And so when you go to the hospitals, another thing that also is that happens when you go to hospitals, please remember to be organized with your information. Have your x-rays in order, tell them your medication history, when is the last time you had a fracture, communicate openly with the health workers, share with them what works, address your concerns about fractures, about pain, and prepare in advance for your doctor's visit, so that, especially in our situation here where healthcare can have its challenges, call ahead and find out if the doctor is available, so that you're minimizing frustration when you don't find this health worker. And so this is one of our young patients who really loves our orthopedic surgeon. And so whenever he gets a time to, they want to take a photo together. And so befriend the doctors. Some of them are really wonderful and they can actually help you in your journey. Create awareness. This young man, who is the one who I showed you who was walking, he's actually writing a book about his experience. Share your experience so that you can be able to replace myths with accurate and human-centered understanding. There are many people who are able to do that. This is a young man called Matthew who has shared his story online. This young lady was featured by BBC, where she's able to share opportunity online. And so use every opportunity you have to share and explain more about OI, and this will help to reduce stigma. And so as you're working together with this way, we'll be able to possibly change the way healthcare is done, engage with the government and health ministries and their patients. One of the patients who I know who is in the rare disease group in Kenya was able to link up with people in the Ministry of Education and Ministry of Health. And she actually sent me a message and tells me that these people do not have guidelines on OI. Please draft a quick guideline and send it to me because I'm going to share it with them. And so you as a parent and a caregiver, do not fear to engage people, because you will actually do things that will actually make a difference. And you can actually contribute to policy and things changing in your countries. Thank you very much for this. And I'd just lastly conclude with this picture of this young lady who has been someone that I've really, really admired all these years. And she was one of the first patients who received biphosphonates in our clinic in 2018. And because of her journey and her mother, who unfortunately right now is late, they have been very, very keen on getting medication. And her and her mom were able to share her zoledronic acid with other patients. And because of that, our cohort has grown from just 2 of them to 84 patients who are receiving this medication every year. Thank you.
Well, thank you so much, Becky, for such a thoughtful presentation. And honestly, it opens new horizon regarding an OI and a lot of questions in mind that how we can basically play our part in advocacy of an OI. So now we are moving towards the last and interesting part of our session, that is Q's and A's. And I would like to request Arnita to please share the question. I will read the questions, and we do have the name of a speaker for which the question is directed for. And I think we have 20 to 30 minutes to address all the questions. So we got plenty of questions for the session. So let's start with the first one. So can we move to the first question? Okay. So I think this question is for Laurie, actually. So Laurie, there was a question that by Asmahan Abdullah. Are there any written and illustrative booklet for parents to guide them through this hard time of handling an acute fracture? That is a very interesting question because everyone is looking for some guideline and written material about it.
So at the beginning, in the notes section, I left some links, and these are YouTube videos to show how to splint a fracture. So those are very informative, so I encourage everyone to check those out. I'll also add a couple attachments here in the message section of these informative little cards. I don't know if you can see on my screen, these little cards that we make that go in our fracture kits. I'll add the picture below so you guys all have access to them.
Thank you. That will be great, actually, because it will be a good source of material for the parents who have joined this session and they can go through it. So next we move to the next question. And so that is a very common question because everyone is asking about what sort of kit you are talking about. And I can see in your presentation about different type of material that you can use, and especially in resource limited countries when you don't have access to all that gadgets. So what do you think the basic things that should be available at home?
Yeah, so like this kit, it's a privilege for our patients in Canada to be able to have access to it. I can go over quickly the contents of it. So this is a Comcast sorry, my screen, I don't know if you're able to see it. We have a SAM splint. So this is rigid on the inside and it bends slightly. We have the informative cards with directions, ACE bandage, elastic, another type of co-band bandage that can be used to wrap. We have felt bandages. We also have a pair of scissors in this kit. We have a little distraction, which is a little bone that acts as a little stress ball. That's not necessary. It's a little fun thing for the kids to have. We also have a type of elastic netting. So these can be used to either go over the bandages to hold it in place, or these can actually be used on a smaller baby, and it goes on the humerus to keep, and it goes over the whole body to keep that humerus in place. So as I said, these are not also always available for everybody. I think the most important thing, if you guys had in your own little fracture kit, is anything that would work to kind of stabilize. And me as a mom, I was out in my community with my children and I was at the park and another kid fell off the monkey bars there. Obviously, I didn't have a fracture kit with me, so that's where the point of being creative really comes in handy. And I was lucky that I had my training from work, so I was able to use that as my my mommy side. And we took a cardboard box and we just cut it in long strips and we wrapped it around the child's arm. And then we did have I think we had a towel with us and we just wrapped the towel around the arm with a piece of tape to hold it. So at least the child's arm wasn't moving. It was well stabilized. And so anything that you can use to wrap would be very useful, such as a scarf cut up in long strips, tape to kind of hold everything in place, and then something rigid. So for us, we have these SAM splints, but for you guys, it could be these long pieces of cardboard, old magazines that can be used to kind of go around. Magazines I've seen used either for the arms or the legs. It's really use what you have.
Thank you so much.
Yeah.
Yeah. Lori, just a suggestion, maybe if you can make a resource for a resource limited country, the alternatives that they can use, that will be very fruitful because many of our participants, they belong to the LMICs and they belong to the resource limited country. So they know that what are the best alternatives they could use at their home. Honestly, that was really thoughtful of you. And I saw some of your picture that was great, that how we can use the home stuff to support the fracture. So can you move to the third question, please? So that is for the Specky. Specky, so there was a question by Dr. Farah from Pakistan that how the advocacy group can lead to the better care. I know this is a very big, broad questions, but what do you think that how they can improve?
Okay, so advocacy groups can be able to advocate for better care because you can actually, let's just think about the three things. So like for prevention of fractures, as a group, you can be able to lobby pharma to actually get zoledronic acid. One of the challenges we had is that we were not getting zoledronic acid in Kenya easily because the number of patients were very, very few. But then now if you talk to a pharmaceutical company as a group, you're able to actually tell them the benefits that the children are going to receive and actually show that even though it's not like for us in Kenya, it's not in our essential drug list for OI, so it's not going to be given in the government facilities unless it'll only be given on an off-label use. But then now through the Pediatric Endocrinology Association, they're able to slowly bypass such red tape, and they can be able to advocate for it being given. And so we're hoping that we'll have more and more access to medication. The other thing that can also help as a group is that you can actually even advocate for those FD nails. Again, when you're in orthopedics, the things that actually have a lot of money are those very big surgeries like joint replacement, where they make more money. But then now with OI patients, at least in our situation, our patients tend to be of the lower social economic status. So companies may not be willing to import those nails because it's not profitable. But as a group, and you actually show that you actually have the numbers, then it's easier to lobby and actually be able to lobby with the regulators to allow you to get a special license to actually be able to import these things. So The other thing that can also help us as healthcare workers is actually just speaking up, talking to people. There are times when you'll actually get into conversations. You're told this child has been admitted in a particular place. I share my number with my Osteogenesis Imperfecta patients, and so if they're stuck in a particular facility and they do not know what to do, they can actually call and just say that this person understands the illness. Talk to them, and so just being available. Situations like that, and we're just basically just trying to fight for the patients, rights. So you know what are the things, how the healthcare system works. So for example, like one of the things that we've had to do is that the insurance only allows us to do 2 major surgeries. The social health insurance allows us only to do 2 major surgeries a year, but this child has come with 2 fractures, and so there are times when you just have to talk with the implant supplier. Why don't you give me this implant on a discount? Why don't you give me at half price? Instead of me paying full price, give me at half price, and then I'm able to do these 2 surgeries at the same time. And therefore, I'll be able to leave one other opportunity for this child to have more health insurance. And even just talking to the administrators, how do you do it? So things like that can actually help.
Yeah, thank you so much, Becky. And honestly, in continuation with this question, I can ask one more question from you actually, that because in many countries, it's very difficult to get it registered. Some people are buying it from unregistered means. So how we can make it in our WHO essential list so that it's a pressure on every country to make it available in every country, even if there are few patients with OI.
So that is something that we need to do. When we actually wrote something with JP last year, but one where we tried to write to WHO to try and amend the essential drug list, and they told us that this drug is only approved for osteoporosis. It's not, you cannot. The only way we can do that is if we do an RCT. And only with an RCT, then we'll be able to do that. So maybe that's something that we can actually do as a collaboration, is to, we know it works, but then we need to do an RCT. And if it's a multi-center trial, which from many countries, then we'll be able to actually give them the evidence that they need. We've actually showed them letters and showed them what has been happening, but they're not budging unless we get an RCT.
Yeah, thank you, Specky. So now we have a question for Korini. So Binish asked, sometime parents report that patient was very active and during that time he got a fracture. So they're really concerned how much mobility should be allowed. I think I can relate to the parents because making them more mobile means putting them more risk of fracture. So how you can maintain that balance? And the second question for you is that which exercises would you encourage for weight control in these children's?
Yeah, these are 2 very good questions. It's right that we encourage children to be as active as possible in a safe way. So I always encourage parents to make decisions to allow children to do physical activity that are going to have as many benefits as possible with as low little risk as possible. So if we think about swimming has a lot of benefits, but very minimal risk. Same thing, like just moving around in the house, doing some gentle movement. It's super beneficial, not that much risk. But if your child wants to go outside playing with his friends, running around, and there's some balls going on, well, the risk is too big. So maybe it doesn't worth it. So it's always a question of finding a balance between the risk and the benefits. Yeah, and it's hard. It's never black or white. It's not, never you can do that and no, you can't do that. It's always communication, talking together. And once again, having the children understand their conditions so they can make some wise choices for themselves. I think that's really important that they, like you said, Dr. Specky, that the children, they can speak up for themselves. If they're somewhere and they feel that something is at risk for them, that they can say it. Just to protect themselves as much as possible. So I don't have a list of things to do and things to do. It's always a question of making decisions together.
Yeah, and honestly, I strongly agree with you because I think the parents and the kids know more than themselves, the other, that which exercise suits them more depending upon their severity. Thank you so much for answering this question. So the next question is, okay, that is for Laurie. Gaspard asked, we are facing a problem of obtaining Canadian visa in order to come and receive medical care. How you guys can advocate for them or other parents who are basically looking for the Canadian visa?
Yeah, honestly, this is a problem we have encountered before, and unfortunately, it's really outside of my scope as a nurse because this really comes down to the Canadian government, Canadian Embassy to decide who they're allowing visas for. Our hospital has provided, we always provide letters for any patient that's accepted as a patient at the Shriners. We will offer a letter saying this patient must be seen. These are the conditions of care with surgical dates or appointment dates. But unfortunately, beyond that, it's really up to the family. We don't know all the family situations, so we don't know why our government's not allowing everybody in. But we do send a letter, and that's standard once the patient has been approved at the Shriners. But from there, it's up to the patient's family to get the visa, unfortunately.
Thank you. And Laurie, even there were a few more questions about some parents that they were struggling to get the letter in support for their travel and immigration for the child help in China. So they were asking about that, how to approach the hospitals, and maybe if you can share the link in a chat box so they can
Yeah,
at least get to know that if they want to approach that, what is the best way? Because there was a lot of questions about that.
Yeah, so I just
Um,
reposted the International Patient Shriners link. So that's
yeah.
the first access of care. So they go there to request the appointment. From there, they'll be given like a coordinator that will help review their file. And that's their go-to person to answer the questions on and the first step of getting seen because these are all the Shriners. It's not just the Canadian one. We used to have more say of who came to the Shriners Canada versus the States, but in the last couple of years with the change in government and everything, the rules have kind of changed. It's been a bit unfortunate for us. So now some of our OI population is actually being seen in the United States. So that's the first step to apply. And then from there, they'll decide which Shriners hospital they're
Thank you so much
eligible
for
for.
this detailed information. So the next question is, okay, so that is for Dr. Specky by Yasmin. Again, it's about how to advocate for a child in a country where OI is extremely rare. So if you would like to answer that.
Thank you. That's a very nice question. I think the first thing is just remember the 3 L's. So you just start by you learning a lot about OI. And then when you learn about it, then you're able to speak better about OI to other people. And then the other thing is to link up with other people. So sometimes, just like this webinar, I found that this webinar has been very helpful. I think we've been doing this for almost, for several years, I think almost a minimum over the last 3 years. That has been a very wonderful tool to be able to actually advocate for it. Last year, we were fortunate, like in Kenya, we were able to get someone from the Ministry of Health to come and attend the webinar. We sent an invitation to them, and so someone from public health came, and so that opportunity for them to get to learn more about it and linking up them with people. And then find other people who have OI in your country. As you're talking to the doctors, ask them, is there someone else who has this thing, and a person who would be open to have a conversation with? And so when you link up with other people, then you can start small and have something like a WhatsApp group, and then you can be able to meet up, talk together, encourage each other. The reason we actually insist on our patients coming together, we've divided them into 2 cohorts where they come 4 times a year, is we try to bring all the patients to come at the same time, because when they're together, they are actually, for us, it's a logistic nightmare because it means they take many rooms and you have to plan ahead for that. But for the patients, it's really powerful because they're actually able to meet with another parent. Another parent can able to show them how do you actually change a diaper. How do you actually take care of a child who has a hip spiker, and you need to change the diaper and not get it soiled, and yet you have to keep this thing for 6 weeks. Then another patient can be able to do that. So linking up with other people is very important. And then later on, advocacy to the government works. So you need to start small where you are, and then you just slowly build it up. And we have not yet reached there. One day we will reach somewhere better, but we're not giving up. So don't give up, just keep pushing and pushing and pushing. And you, whether you're a parent, a patient, or or a physician who is treating OI, you have a lot of influence. So don't underestimate your influence. Just talk, share your story. You never know who will be willing to listen. Yeah. Something
Thank you.
simple as
Yeah. No, thanks, Becky. That was a wonderful, because you need to start from somewhere, and I think making a WhatsApp group is the best one. So the more and more the families they can join, and then they can raise their voice together. Thank you so much for such a nice idea. So shall we move to the next question, please? So this is a question for Karini by Asmahan Abdullah. Can you highlight, please, the best exercises that parents can do for the newborn, especially who were born with in utero fracture?
That's a very good question. Thank you for that question. Actually, for all babies and infants with OI, the general principle is to encourage them to do everything that they're able to do. So if they're able to move their arm, move their legs, roll on their sides, then you let them do it. All active mobility is encouraged to strengthen the muscles and the bones. Of course, not when there's a fracture, it has to be immobilized. So all active mobility is encouraged. And also I would say, like, for babies, it's really like for the parents to be comfortable at handling their child. So really, once again, open your hands, pick them up under the bum, under the head, close to you, just so the babies, they're feeling safe, and it's as safe as possible. Yeah, so for that's for babies, and just for like any baby, eventually have them lay on their side so they can play a little bit on their sides, and when they get stronger, have them go on their tummy eventually and develop their head control. But the key word is really active mobility. You want the muscles to contract, to pull on the bones, to strengthen the bones.
Thank you so much, Karini, for such a detailed explanation. So the next question, I really want to take as much question as we can in our time. So there's a question again for Karini for you by Dr. Kavari. It is about, do you think mild swimming, water walking, and hydrotherapy maneuvers strengthen the bone and muscles, and they could be beneficial for the cardiovascular system?
A big yes. A big yes. Moving in the water, it's so wonderful for the cardiovascular system, for the muscles, for the bones as well. As I said, it's really the muscle contractions that we want. So you can have those muscle contractions in the water just from moving the legs, moving the arms in the water, standing in the water, walking in the water, doing some swimming, either with some help or without the help. But for sure, swimming in the water is really good. Earlier, we talked about risk and benefits. So moving in the water, playing in the water, walking, swimming has minimal risk. Once again, the risk is never zero, but the risks are very low of having an injury while moving gently in the water, and the benefits are really big. So swimming, if it's accessible for the children, the families, this is something that is highly encouraged. And also when the bones of the legs are weak or deformed, standing on land can be too risky. The risk of fracture is way too high. But standing in the water with the water buoyancy, with the water supporting the body weight, then often children, they can stand and walk in the water if they have water up to their shoulders. I think standing with water up to your shoulders, you only have 10% of your body weight on your legs. So standing and walking in the water is a lot safer than on land when you have fragile.
Thank you so much, Karini, for this detailed answer. And the next question is, shall we move to the next question? So this is from Kim, and the Kim is asking, why do we suggest to get bisphosphonate on PMB? My insurance refused to pay for Zobone and Zometa. Maybe Specky, if you want to answer that.
Well, many insurances will refuse to pay for biphosphonates. But when you think about it, one of the conversations we once had a particular treatment, we told them, do you want to pay for this preventative one, which is cheaper? Or I wait until this person fractures And then now you have to deal with the hospital stay, implants, surgeon, and all those things. So make a choice. So sometimes you just have to have those tough conversations and with them. But then also, if they refuse to pay, when you think about the cost benefit of actually giving the zoledronic acid, it makes sense to actually to save money and buy it. If you're giving it to a child who is less than 2 years, you're giving it every 3 months. If it's to a child who is above 2 years, you're giving it every 6 months. And so just that alone for zoledronic acid, even though it might be it might be a bit more expensive than other medications, but the benefits outweigh not
Yeah.
giving it.
Yeah, honestly, maybe there's a need to conduct a study on it that for the government, especially that if you are not supporting the bisphosphonate, that how much you are spending in hospital admission for this patient, and actually you can save a lot of money by providing this medicine. Just a thought. Well, thank you so much for answering it so well. And shall we move to the next questions because we are just left with 7 to 8 minutes. So again, Asmahan has asked a question. Is it always a challenge for a new, it is always a challenge for a new parents to handle a baby with OI, especially bathing, changing diaper, changing clothes. What are your advice for such a couple? Maybe Laurie, if you want to answer that. So what do you think?
Yeah, we're lucky that we have both Corinne and an occupational therapist working in our multidisciplinary team. So every patient that comes is seen by all of us. I think Corinne is maybe better at answering this question, but yeah, it's a team approach and it's a lot of teaching. It's a lot of time with these parents to make them comfortable. That's why we try to get them in to the hospital to see us as early as possible when the baby's very young so that they are more comfortable at home.
We have a little booklet. It's called Daily Care of Children with OI. So there is some recommendations on how to change a diaper safely, clothes, handling of babies with OI. So I'm going to try to see if I can put the link in the chat, or if not, maybe I can just email it to GPED and it can be on your website. Yep.
That will be great, and honestly, because I was just thinking by all this conversation, we can create a OI corner on a GPED where we can share all this information so that family can approach it and get all this information, all the links and everything. If Agostini and the other organizers allow for that, because it's a great source of information for the parents, actually. So, shall we move to the next question, please? So this is questions by Tarila Agati, who is a founder of OI of Nigeria, OI Foundation from Nigeria. Is there a possibility for Shriners Hospital to support with mass surgery in an African country outside through the existing OI organization existing in the country and soundly support the organization with zoledronic acid? So they just want to ask that, do you think the Shriner Hospital can support other organization in Africa by providing them the medicines and in surgeries?
I know that Dr. Hamdi, he's our orthopedic surgeon. He actually just came back from Africa last week. He was there doing a week of surgeries on the Ivory Coast, I believe it was. We also have a family from Ghana that we're working very closely with. The mom is very strong advocate for the OI community there, and she's trying to set up a bigger OI population of caregivers there, also surgery. So we have been working with her the last few years to see what kind of support the Shriners can offer, maybe to teach new surgeons how to do these rotting surgeries. I think beyond that, I think maybe it's outside my scope to be able to say what the Shriners is able to do in terms of providing surgeries in other countries. But I know our doctors are always very eager to help answer questions about surgery. So if your surgeon in your country has questions, our doctors are very open to looking at the x-rays with you and providing support that way as well.
Thank you so much. And even like in our country, Pakistan, my hospital is running a big OI center. So they contacted the local organization. We selected a day. Actually, on that day, the patient used to come so that the medicine is not going to be wasted. So that was the whole point because it's very difficult to get the medicine. Some kids need tiny dose, some needs more doses. So we are managing like this by contacting our local NGO, and they are providing us free of cost the zoledronic acid. So I'm just thinking the role of the local NGOs to support OI. Why not? Yeah. So shall we move to the next question? I think we have 5 minutes left. So this is a question by Ioha. And can Shriners Hospital support the treatment of glaucoma in an osteogenesis imperfecta? So a lot of questions for Shriners Hospital about how they can support.
Yeah, so the Shriners does great work. The Shriners in Montreal, it's specialized in orthopedic care. So we do give the bisphosphonate treatment as well, of course, and the surgeries. But glaucoma, it's not something that we offer. We have started offering dental support, but that does not include orthodontic support. But glaucoma, no. However, again, there's other Shriners hospitals in the States. I'm not sure if this is something that they would offer, but in Montreal, unfortunately, no, it's not something.
Well, thank you so much. And the next question, please. So, Binish asked a question. Can you please guide us about the safe transportation of a patient to hospital? I assume it is about if a kid is having a fracture, that is my understanding, or maybe, I don't know. So, how we can transport a patient from home to a hospital?
Okay,
Shall I
so this
ask
is
Laurie to answer that? If a patient is having a fractures, and you have already
sure.
explained that, yeah.
Yeah, so I already did explain that. It's just really important. That's why to splint right away at home when the fracture happens, because we never know how bumpy the road is, how long it's going to be, how long you might sit in your emergency room at your hospital waiting for x-rays or medical attention. So as long as that fracture is well splinted, there's less of a risk of displacement. In Canada, we have a lot of laws of seatbelts and car seats for children. I know that is not necessarily the case in every country. So our occupational therapist, for example, if our patient is going home in a spica, she's able to look at what type of car seats are available to be able to fit this patient with their spica cast into car seats, and that they're still well attached for transportation home.
Thank you so much, Laurie. So the next question, please. So Fatima from Pakistan is asking from Specky, is there any global advocacy program where the families with limited resources can join too? And she feels that more than advocacy, there's a need for a group to support the parents who are taking care of these kids, because sometimes we feel isolated and we need support too. That is my understanding.
Thank you.
The
That's actually
caregiver.
yes, that is so wonderful because I mean, most times people just think about the patient, they forget about this parent who is constantly stressed. And so there are different places that you can actually join. There's a OIFE, it's in French. Let me not massacre my French. So translated Federation, the European Federation of Osteogenesis Imperfecta. And so that's one place that you can join and you can actually be able to attend. They usually have a conference every year. And so you can actually attend there and learn a lot of these things. So that's the main one, and I think there's also Brittle Bone Society. That one I don't have much experience with, but at least with OIFE, I've been able to participate in some of their conferences and actually listen and learn. And there are many of those groups which are regional. Yeah, but I think this is an opportunity for us to actually even work together and collaborate and actually see how we can actually be a support group. You see, the advantage of the internet is that you're in Pakistan, I'm in Kenya, and so are other people around the world. So it's something that you can actually see how we can actually support each other. And you're feeling stressed, reach out to someone, text them and tell them, if I hear one more fracture, I'll lose my head. So, and there are mothers who actually do so, and they actually have a wonder, they talk and they feel like crying and they feel like giving up, and another mother will actually call them and tell them, you know what, I understand what you're going through. And so
Yeah.
it's important to actually meet other fellow people like you who can actually be able to help you. I just want to spend 1 minute to talk about public transport. Transporting patients to hospital. Sometimes you may not be in a position to actually sprint the patient and you just need to travel. Ask your neighbor if they have a car. That might be easier than using public transport. But if you're stuck and you have to use public transport, what we found, like in Africa, is if you talk to the driver, he'll allow you to sit at the front. And if you're at the front, he will be very compassionate. Most of the people, if they understand what condition they have, they can actually make exceptions and they can actually help you actually drive into the hospital, to the emergency room. So even public transport, if you have to use that, just have a conversation. People are actually caring until you ask. They might look very, very tough, especially us in Africa, the touts in public transport are very tough. But if you talk to them, I have seen them to be very, very cooperative. And sometimes they see some of these patients and they actually tell other people, you can get out, put this person to sit over here, and they can actually help you.
Yeah, thank you so much. We were actually short of time and there were a lot of questions which were still pending. I think, Corinne, you raised hand. You want to say something, just a key message about your presentation. Please go ahead.
Actually, I've put it in the chat. I just wanted to mention that, yeah, in Europe, there is the OIFE and there's the British Bone Society in the UK, but also in the United States, there is the Osteogenesis Imperfecta Foundation. They have a wonderful website and they organize a lot of webinars also and virtual support groups for children, teenagers, parents, women with OI. For sure, with the time difference, it can be a little bit challenging.
Yeah.
If it's at 7 o'clock
Yeah,
in the
yeah.
States, maybe it's in the middle of the night in Africa, but I've put the website there just if you're interested.
Yeah, thank you so much. So now we are heading towards the end of the session, and I'm really grateful to all the three speakers, Laurie, Corini, and Specky, for the wonderful presentations, and a great thankful to all the families and healthcare professionals for joining us today. Your presence and engagement means a lot to us, and I'm truly grateful to our GPED leadership, Augustini, and our organizers, Arinita and Vania, who were actually working at the back throughout for arranging this webinar. And it's my pleasure to moderating these sessions. And over to you, Aranita, because she had some announcement for you. And thank you so much from my side.
Very much, Dr. Somaya, and thank you very much to all the speakers as well. So before we conclude, we will now have a photo session. So let's have the speakers spotlighted once again. And to all the participants, please turn on your videos as well. I'll take the photo. 1, 2, 3. First slide. 1, 2, 3. To the next slide. 1, 2, 3. 1, 2, 3. That concludes the photo session. Okay. To all the participants, please fill in the feedback form as detailed on the slide and that has been sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. GPED conducts routine webinars as well as other very exciting activities and opportunities for you. In fact, next week we will be having a second webinar in conjunction with Wishbone next Saturday for healthcare professionals entitled OI and LMICs, integrating recent advances into resource constraint settings. We will also have a webinar on World Thyroid Day, which will happen at the end of May. Further information will be shared within the next few weeks. Furthermore, on the 22 to 23 and 28-29 November 2026, we will also be hosting the third GPED annual meeting with a very exciting theme, Doing More with Less, Managing Pediatric Endocrinology and Diabetes in Challenging Settings. Registrations and abstract submissions will open this month, so please stay tuned. And to keep yourself up to date, we urge you to follow GPED on our social media platforms as detailed on the slide. Furthermore, register to become a member of GPED via the GPED website as seen on the slide. Once again, warmest round of gratitude to all our speakers, our moderator as well, who have made this webinar a great success. Thank you, and we hope to see you at the next webinar.
Thank you. Bye.
Thank you very much.